Hello and welcome to the Spine Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And we just wanted to take a second to thank everybody for tuning in. We are endeavoring on some new ideas and new ways of presenting information, so please let us know if you have any feedback for us as to how we can continue to provide value for everybody out there. We wanted to start back at some of the earlier stages of pain medicine and musculoskeletal pain, and so we started with the chronification of pain and started with our new thing of going into the science and then presenting a clinical study on it and then a little bit of a case presentation. So today we're going to continue some of the earlier work and go back to myofascial pain, because I think myofascial pain is something that is omnipresent in our patients and is something that is easily overlooked, and I think definitely our patients tend to not appreciate how much that can play into their disability and play into their overall pain processes. So Dr. K, can you give us a little bit further of an introduction?
Yeah, and so today we'll talk about definition, epidemiology, some of the pathophysiology, and along the lines that Dr. Joves was mentioning, this is a very common condition, and I think, for probably various reasons, both the provider as well as the patient doesn't necessarily always want to say that, hey, there's a large role here in terms of myofascial pain. It's almost, and again, I don't know if this is best summarizing it, but when patients have these significant debilitating refractory symptoms that are majorly impacting their lives, sometimes I feel like we don't want to attribute it just to myofascial pain. And one thing that we'll talk about is that myofascial pain oftentimes is secondary to another process, but still, as Dr. Joves alluded to, can play a very major role in terms of the overall clinical presentation.
Yeah, I think it's always generally really hard to present the muscles as a component of pain to patients. They really don't like hearing that part of their pain is muscles, and I think you'll kind of get to it, but especially when we see some of these acute on chronic flares, muscle spasms are an extremely painful thing, kind of speaking from personal experience, but patients really dislike hearing that it's a part of their overall pathology.
Yeah, it's almost like we're minimizing it, but that's very much not the case, and I think that's the important thing to try to get that. And sorry, I guess that's what I was trying to say earlier. And by no stretch of the imagination, that's what we're doing when we're incorporating it into our differential and our treatment plan. So in terms of the definition, myofascial pain is a painful condition that arises from the muscle and the associated connective tissue, typically presents as regional pain with associated increased tension, decreased flexibility, and range of motion. Most definitions, when you go through the literature, most of the definitions of myofascial pain consider the presence of myofascial trigger points to be a critical component, which trigger points, which we'll get into obviously in more detail as we move forward here, are discrete hyperirritable nodules in a taut band of muscle. These myofascial trigger points cause pain in the surrounding tissues and distant sites, in particular referral patterns, which obviously were mapped out through the work of Travell and Simmons, as well as others. And these trigger points can be spontaneous and or inducible depending on whether or not they're in their active or latent state. Moving on to the epidemiology. So as we had brought up in the beginning, myofascial pain is incredibly common. It's very prevalent, affecting about 85% of patients in the chronic pain clinic setting. If you look at epidemiologic studies for more the general practice clinics, internal medicine clinics, still prevalent, but closer to around 10% of patients coming into those clinics having significant myofascial pain. And then looking at the overall general population, just in terms of dealing with myofascial pain at some point in your lifetime, So those epidemiologic studies would show about 85% of the general population will present to their provider, present to their clinic with a complaint of myofascial pain at some point in their life. So as we brought up in the beginning, a very common condition. Now, real quickly, in terms of the diagnostic criteria, especially from a myofascial trigger point standpoint, there is obviously ongoing continued controversy here. However, Dr. Gerwin and his colleagues in the 1990s did propose the following diagnostic criteria for myofascial pain and specifically myofascial trigger points. So that criteria was exquisitely tender spot found in taut band of muscle, a local twitch response and/or referred pain to a distant site upon manual palpation or needling of the tender spot. And I think any of us who've done trigger points can attest to that, not only when we're trying to find the trigger point on the patient, but also when we're injecting that trigger point. It's very common for the patient to say, okay, I feel a shooting pain that reproduces my symptoms, and obviously that's somewhat of a good sign from a treatment perspective that we're probably right where we need to be to deliver our treatment. The remainder of the diagnostic criteria: restricted range of motion, reproduction of patient's symptoms through pressure on tender site, regional muscle weakness, and autonomic symptoms. And we'll get into that last one, the autonomic symptoms, why that makes sense. And that kind of goes back to our earlier talks on chronification of pain and the crosstalk between different nerve fibers as they are interplaying with each other. So, like I said, somewhat controversial, but those are some of the diagnostic criteria. Now, moving to the pathophysiology before we get into some treatment considerations. So, muscle pain involves nociceptive specific neurons in the spinal cord and brainstem and activate unique cortical locations, and those cortical locations, specifically for myofascial pain, are significantly associated with the emotional, affective components of pain. Typically, at baseline, the nociceptive pathways from the muscle are more potently inhibited by the descending inhibitory pathway relative to other areas. So, and that makes sense too. But if you compare the baseline descending inhibition from something like your skin relative to muscle, there's not going to be as much descending inhibition from those cutaneous nociceptive fibers. And like I said, that can make sense from a protective standpoint. If your skin is your first barrier, you want to know if there's fire, or if there's something sharp, or if there's something dangerous. You don't necessarily want strong descending inhibition of that. In contrast to the muscles, like I said, at baseline, have a stronger descending inhibitory pathway. However, with persistent nociceptive input from this myofascial tissue, it's actually more prone and more capable of producing maladaptive neuroplasticity in the nervous system, including at the level of the dorsal horn of the spinal cord. And we'll go into this in a little more detail today, but obviously that goes back to all the discussions we had in terms of chronification of pain. Active significant trigger points are a source of ongoing peripheral nociceptive input. So like we talked about, when you have this pathologic state and you have this more consistent, significant input of nociceptive signals from the myofascial tissue, that does induce some level of sensitization, both from a peripheral sensitization standpoint as well as from a central sensitization standpoint.
So can I ask one question for clarification?
Yeah.
So you're saying that our muscles and our general myofascial system, the muscles, the overlying fascial tissue, tendon attachments and such, are more prone to pain chronification than, say, our skin is?
Correct. Yeah. So, once it gets to that pathologic point, they're actually, those nerve fibers are actually fairly adept, or I don't know if that's the right way to put it, but fairly prone to developing that chronification state. Yeah. So, work still remains to be done to fully understand this pathophysiology of myofascial pain. But, one approach to understanding this, which has been explored, is to evaluate the objective biochemical differences between an active trigger point, a latent trigger point, and normal muscle tissue. And so when those studies have been done, what they have found is that there is a unique and reproducible difference between those different sites, the active trigger point, the normal muscle tissue, and the latent trigger point. So specifically, patients with active trigger points have local, significantly elevated levels of certain substances, including substance P, calcitonin gene-related peptide, bradykinin, serotonin, tumor necrosis factor alpha, interleukin-1 beta. So all these things, as we've talked about in the past, are associated with peripheral sensitization of nerve terminals, and obviously, ultimately, worsening symptoms for the patient. So, like I said, in the study of an active trigger point, those are elevated relative to the controls in the studies who had normal, quote-unquote, normal muscle tissue. And the conclusion from those studies is really that an active trigger point has a highly significant objective difference and measurable difference in terms of that biochemical milieu. Now, one of the important things in terms of all those things that we mentioned to be elevated, and they all have a certain role, but specifically increased calcitonin gene-related peptide enhances the release of acetylcholine from the motor end plate, which ultimately leads to decreased effectiveness of acetylcholine esterase. So obviously, that's going to lead to even further buildup of acetylcholine in that synapse, and upregulates the number of acetylcholine receptors on the muscle. So essentially, you're leading to this persistent focal muscle fiber contraction. And we can understand, how that could be problematic for the patient, and how these patients have persistent kind of muscle pain, muscle tension, and muscle spasms. So I bring that up just as an example of, we have these objective measurable differences from these studies, and this is, how they can be problematic, and calcitonin gene-related peptide just being one of the examples there. So the constant peripheral nociceptive input from the myofascial tissue, like we talked about, induces these maladaptive changes in multiple places, including at the level of the dorsal root ganglion. And the peripheral nociceptive input and the changes in the dorsal root ganglion ultimately contribute to central sensitization, including what we've talked about in the past in terms of decreasing that activation threshold for the neurons in the central nervous system, but then also increasing the amplitude and the frequency of the firing once they are activated. And then, kind of the end result of that, we're seeing the reorganization, the structural reorganization of both the spinal cord as well as at the level of the brain itself. So some other real quick things to mention in terms of the pathophysiology is that with this persistent ongoing nociceptive input, some of the other changes that we tend to see is that you actually start to have apoptosis of the inhibitory interneurons at the segmental levels. And so, like I said, multiple things that are all coming together to contribute to the fact that, we brought up in the beginning, simple, again, not just simple muscle pain, but, this is kind of starting to understand how myofascial pain, how muscle pain can be so problematic and so chronic and refractory for the patients. And I think figuring out a way to explain that to a patient efficiently and in a way that they can understand and really take home with them to begin to understand their symptoms and what they're dealing with on a day-to-day basis better I think that will ultimately help in terms of making progress with their treatment.
Yeah, I mean, I think it's can't be overstated enough, right? Like patients and probably practitioners also think about myofascial pain or muscle pain as this kind of garbage bin, you don't believe I have real pain thought process. But obviously, we're talking about, very objective data that shows that there are significant changes at the level of the muscle. We have muscle that is at a higher propensity for neuroplasticity than something like skin, and we have very significant inputs for peripheral and central sensitization coming from these muscles. And so I think we have to be able to explain this, like you said, in a way that people can understand, not just the patients, but also the people that are seeing these patients, to understand that muscular pain, myofascial pain, trigger points are a legitimate part of the pain process, and B, likely a very strong contributor to their overall clinical picture, and something that should be a part of it. Like you did allude earlier, a lot of times these happen because there's something deeper that's going on, and of course we're always going to be looking for the best ways to treat that deeper pathology, but this is absolutely a significant component of their pain processes.
Yeah, and definitely. And the last thing I just wanted to mention in terms of pathophysiology is that another unique thing about the muscle afferent nerve fibers and the nociceptive input from those muscle fibers is that they preferably activate the lamina 1 and 5 in the dorsal horn. So as we know, the dorsal horn is broken up into different lamina. And so those myofascial nerve fibers, as they come into this, to the dorsal horn of the spinal cord, like I said, preferentially activate laminas 1 and 5. And when we think about the wide dynamic range neurons, which we have brought up in the past in terms of playing a major role in the chronification of pain, and pain becoming more diffuse and starting to involve distant areas rather than just the site of the pathology, the original pathology. So those wide dynamic range neurons are localized heavily in laminas 4 and 5, and so obviously that crossover of the myofascial nerves coming in and interacting with lamina 5, and that having a high level of the wide dynamic range neurons. So this, helps explain multiple things that we have brought up, but also the fact that these how muscle nociception can actually spread to other structures, including the viscera and vice versa, and again, contributing to the difficulty treating it and sometimes the difficulty diagnosing it because, again, like we talked about with other chronic pain states, becoming more diffuse and difficult to localize. So now that we've kind of covered the definition, the epidemiology, the pathophysiology, we wanted to finish up by discussing treatment. And so, like we brought up many times before, create your algorithm that works best for you. I brought up lifestyle modifications, activity modifications, therapies, medical equipment, medications, obviously in this case very much including topicals, procedures, obviously in this case very much including possible trigger point injections, and then obviously some of the other things that in terms of consults like acupuncture consultations can be very useful in these settings as well. But I do think that we wanted to specifically, from a medication standpoint, from an oral medication standpoint, we've talked about in the past, and I think that is very much true in this case, where baclofen and tizanidine, given their mechanism of action and their relative side effect and safety profile, I think are attractive choices here. But the other thing that I think we wanted to discuss was the option of topical medications because, obviously myofascial tissue, I think being a little bit more able to treat to some degree or more affected by these topical medications, and obviously some huge benefits with topical medications, including significantly less systemic uptake, make them attractive from a side effect and adverse effect standpoint as well.
Yeah, and I think one of the things about thinking about treatment of myofascial pain is educating and convincing the patient that consistency is important, right? I mean, just like with everything else, obviously consistency is such a massively important thing for all pain treatments, for all, you know, musculoskeletal joint rehabilitation. Consistency is important, but especially for myofascial pain. I feel like it's probably beyond what we would talk about for things like, you know, the back or the knee or the shoulder, because, you know, if we just slip a little bit, you can kind of let those muscles get back into the pathways of that peripheral and then central sensitization. And so, you know, making sure that we are on top of things, and you know, I think, you know, similar to you, my process is usually conservative to invasive, right? So as we're thinking about all of those tools, right, the exercise, the massage, the acupuncture, chiropractic, you know, myofascial release, topical ointments, you know, it's figuring out the ways that those are tools that can be used on an ongoing and regular basis. You know, if you can, you know, utilize a topical ointment, which then helps you to do a little bit of maybe myofascial release while you're doing it, or at least, you know, kind of rubbing that area to be able to allow the medication to penetrate, you have two things happening, right? Obviously, you're delivering medication, which can, you know, depending on what's in that topical ointment, can, you know, increase blood flow, can decrease some of the local receptor pathways, but you're also providing some tactile feedback, you know, which is going to, you know, myofascial release, generally speaking, is going to increase blood flow, right? You're going to try to loosen up those tight muscular fibers and try to bring blood into that area. I think generally when I'm talking to patients about something like myofascial pain, and it's really thinking about ways to consistently get sustained blood flow to those muscles so that we can try to wash out, is the way the term that I usually use. I know it's not scientific or anything along those lines, but try to get rid of a lot of those signals that we don't really want there. And so trying to do, you know, consistent exercise and light aerobic activity to be able to, you know, bring gentle blood flow, to be able to do things like massage on a regular basis, and whether that's, you know, yourself kind of rubbing into an area, you know, getting something like, I don't know, Theragun or something like that, which I've had the pleasure of being able to play with recently, which I think is pretty cool, or having, you know, working with somebody trained in appropriate myofascial release, like a physical therapist or massage therapist, that can really kind of get in and do it, but then utilizing other tools to allow you to have that same benefit on a regular basis.
Yeah, to your point, you know, in terms of, because I think like many chronic pain processes, ultimately it does, you know, take a multimodal approach to really have the success that we're looking for the patient, and then the consistency too. You know, it's you know, especially if the myofascial pain syndrome, or if the myofascial pain is the predominant cause, like you said, I mean, if a patient comes in and gets 1 or 2 trigger point injections and then they're like, all right, this isn't working, then, you know, that's there's multiple problems there, and you know, part of it is making sure the patient understands up front that the plan is not to solve this with 1 or 2 trigger point injections. The, you know, trigger point injections are one part of a significant multimodal approach to care that, you know, includes their home exercise program, their stretching, their continued work on their posture at home, the use of the topical medications multiple times a day, like you mentioned, trying to have a positive impact on that biochemical milieu, and trying to give them good, normal sensory sensations intermittently throughout the day, and then, you know, utilizing the formal physical therapy, utilizing the trigger point injections in a strategic fashion, where we're not doing, you know, multiple trigger injections every single week, but we're getting longer and longer benefit with the trigger point injections. We're utilizing them for flares, and they're more and more effective because they're paired with all these other treatments for the sustained benefit for the patient.
Yeah, and I think that's, you know, obviously with all things pain medicine, multimodal treatment is the preferred way that we want to convince patients to do it. But absolutely, when there is a strong myofascial component, I mean, getting into that routine of doing all of these things, you know, like you said, multiple times on a day-to-day basis, right? It is not the easiest thing in the world to, you know, remember if you're sitting at your computer to, you know, to fit in your 5 to 10 minute stretching routine for your neck and upper back, you know, to, you know, as you just did right now, kind of work on that posture and kind of bring your shoulder blades back and down so that we have the right sitting position, so that our head is over our shoulders and we're not putting extra stress, you know, on our, you know, posterior chain, which is a very common problem, right? I mean, I think, you know, we've talked about things like technology neck and things along those lines, which, you know, obviously has a strong myofascial component as part of it, but really figuring out how to introduce all of these different tools into our day-to-day and into multiple parts of our day, so that we are kind of staying on top of it. You know, 3 to 4 times a day is generally what I would try to convince patients that they need to do if they're going to get, you know, the best out of their routine.
Yeah, definitely.
Anything in closing that you feel like we haven't necessarily covered appropriately at this point, talking about our nemesis, myofascial pain?
Nope, I think that's it. Thank you guys for listening, and have a great week.
All right, guys, we will be covering some semblance of a recent publication on myofascial pain next week, and I'm excited to figure out what it is, because I don't know yet.